Hey guys, we have a hot topic today to discuss. We're back with the 4th episode of the Lab Lowdown. As always, I'm Angela. This is Tom Wyan, CDT and lab owner of Wyan Dental Lab. So let's get into it. FP1s, right?
Yes.
There's a lot of talk about these, some controversial things about these, some things that are good, reasons why maybe people stop doing them and we're seeing them trickle back. So I don't know if you could talk a little bit about like the actual benefits of doing these.
Yeah.
Yeah. And
Yeah,
what
so
that
we'll start
means.
there, right? Because there are benefits to it. And then, why do we stop doing these and FP3s? And
Yeah.
so benefits of an FP1 is you're just replacing teeth. You're not reducing a lot of extra bone to be able to create space for the prosthesis. So huge benefit if you have a younger patient and you have good bone levels to start with. You can just extract the teeth and then you do an FP1 bridge. We'll get into the workflow later, but you have minimal bone reduction and you're just replacing the teeth. So that's a huge benefit. Another benefit is if they are a younger patient, say they're 40 or even 50 years old, the question is becoming what does the life expectancy of an implant look like?
Yeah.
20 years, 25 years, 30 years down the road. So you're 40, when you're 70, what does this situation look like if you had an FP3 done? If you had a lot of bone reduction and now we have resorption around those implants and it's 20 years later, 25 years later, depending on your health, that may be worse or better in some patients. If they have to be retreated, now you're looking at, we've taken all this bone away, we need to do zygomas to retreat this patient. If you started out with an FP1, you have bone left there that you could retreat that patient, remove the implants, take the bone away, and now they become an FP3. And now that's probably the last restoration they'll need in their life, and they don't have to go all the way to a zygoma.
Got it.
So there's a real benefit long term. You're not taking as much bone away. So the other thing is an FP1 is more like the patient's natural teeth. So you have the implants, most likely 6 to 8 implants rather than 4. So you have the contours of teeth. You don't have any artificial pink gingiva. So it feels like and functions more like the patient's actual natural teeth. So those are the real benefits of FP1.
Yeah, which sounds like there are a lot of good benefits when
Sounds great.
used accordingly.
Exactly. So it sounds great. So the question is, well, geez, why did we stop doing FP1s on a regular basis? We're not even considering them at all. So we have to back up and remember what All-on-4 accomplished and what it means. So 25 years ago, if you were getting full arch implant dentistry, it was an FP1. The All-on-4 wasn't a thing. Off axial loading implants to, distalize to maximize AP spread. The goal of an All-on-4 was to minimal implants, tilt the implants so you maximize the AP spread. So on 4 implants, you can do a full arch restoration. The idea was cost. These are $60,000 to $80,000 cases, FP1s, to get down to a 30 or even less in today's world.
Yeah.
So depending on the materials, depending on the efficiency, whatever, but you get the gist. You go from 60 to 30 or less. Yeah. So you're able to treat more patients. It's much more affordable restoration. But if you are going to do FP3s on every patient, then you are going to take a lot of bone away, which retreating later on could be a potential issue.
Yeah, that's true.
So you have to then choose your cases carefully with FP1. So we can't swing the pendulum too far in one direction or the other. So I think it's very responsible dentistry to consider an FP1, but at the same time, everybody's not an FP1, just like everybody shouldn't be an FP3 if you don't need to take that kind of bone away and if they can afford the treatment plan. So if, for instance, patient has a high smile, when you extract teeth and even when you put implants in, depending on the positions, you can expect resorption in the anterior maxilla, for instance. So if they have a high smile, you can expect that bone to pull back 2 to 5 millimeters. So if we planned on an FP1 and we have the teeth here and the ridge started out here and now we have resorption, now we have to fill this gap somehow. You end up with really long teeth. You may end up with an FP2 in that situation. So you want to avoid a high smile line patient. Patients that have an edentulous ridge If there's an edentulous space, you're not going to be able to develop those pontics and develop a sulcus. You're going to, because those teeth are already gone, that bone's remodeled, so you're not able to do that. The best candidate is somebody with a low smile, high bone levels when you extract the teeth, and then you can extract all the teeth and then develop all of those sulcuses with ovate ponics. The other thing we recommend with an FP1 is guided. So it's important. FP3, you can get 4 implants in, they become anchors. So it's not as critical. There's a lot of leeway with the implant position. FP1, you really want to have those implants coming out the central fossa. You don't want them having up too far lingual. So we recommend extracting only the teeth where the implants are going to go. We do a guided, place the pilot guide, then we remove the remaining teeth. And then go from there. So it requires a surgical guide, which adds extra cost. So again, one of the problems is we're really jacking up the price again pretty quickly.
So every case sounds like can't be treated the same. Can't treat every case equally because they're different. There's a solution for them, but it could be a different solution if you don't make that right choice for that patient. Then that's where you see what I would consider not a great success.
Because you don't. The worst case scenario, you don't want to tell the patient, promise the patient, this is what you're going to get. And then surgery gets done, bone remodels, higher smile. Now you have an aesthetic challenge. And it's like, it is not ending up to be what I expected. So you have to just choose the patients very carefully. It's a great option.
Beautiful
but choose
option,
them carefully.
Well,
and there's lots of benefits too. So another thing that's changed in 20, 25 years is 25 years ago, this was, you would extract teeth, place implants, you would do a handmade provisional, and you'd contour all these conics and everything. Now, in the digital world, we extract teeth, we scan, we take a digital diagnostic, and we finalize all the ponics, how they contact the tissue, we compress tissue more accurately, and then we can immediately produce a milled PMMA prototype. So the digital workflow really makes it a much more streamlined process to provisionalize the patient. And then once you have them provisionalized, you're basically making some minor improvements, but you should be copying pretty much what you did.
You're most of the way there.
Yeah, you're most of the way there. So the digital workflow has made it leaps and bounds better restoratively, but choosing your patients carefully.
Do you think that's why maybe with the emergence of digital and, some people having differing opinions on leaving bone, taking bone, all those things, giving options now that seem more doable for people to do the FP1s?
Yeah, I think for sure that the digital has made everybody think, hey, we're doing all on fours with a full digital workflow now, right? So we're not doing a chairside pickup. We do that, but we can do a scan, and then we can do a digital design, and we can deliver a milled PMMA same day or next day. So your mind now is thinking, oh, well, we could do an FP1 this way too. This would be a very efficient workflow. Agreed. However, patient selection still is critical. It's not a one-size-fits-all. So don't think that we're going to do every patient FP1 because I don't want to take bone away. It's still, patient selection is still critical in those situations.
Yeah, definitely still critical and still important, where if you have a patient or you are a patient and you're considering that, would be important for us. We would like someone to call in, the doctor to call in to have that conversation with Tom, because, he can definitely help you sort through the finer points to determine if that is a good candidate for that or if the patient is not, because, at the end of the day, it does require a lot more, it's technique sensitive.
Very.
So it's not like an FP3 where we have more wiggle room for certain things. It's definitely more specific. So
yeah, and we like to start with, if you're a restorative doctor, a DICOM. So we can see what the bone levels are going to be, how much recession is already under there. So as soon as they extract teeth, where's that bone level going to go to? Intraoral scans, so we can evaluate the tooth positions. Good photo series of the high smile, especially, but the normal photo series in repose and cheeks retracted, but that high smile is critical. So we can see if you can see the transition line where that's going to be. So typical workup stuff that we would always want, but even more critical, especially having that DICOM, so we can treatment plan the case from the ground up.
Yeah, I think it's good we do that because there are, so many hot takes on it and so many opinions on it that I feel like, letting people know that this is something we can't do. We don't dislike it. It's great, but just when used properly, because we've all seen those photos where, the implants are hanging down and it's, it just looks like the bridge is hanging there. The FP1's hanging. Because it wasn't probably
and when they're done well and the patients are selected properly, they look amazing. And so, of course, everyone looks at that and thinks, that's what I want. But not every patient is the same, and they may not be a candidate for that.
Yeah, well, definitely.
But they may be also.
Yeah. Well, if you want to find out if your patient is a candidate or not, feel free to call into the lab, ask for this guy right here, Tom Wyan, because he will be the one to lead you in the right direction. And he'll be honest if it's not gonna work, if it's not a good fit, because we'd rather have that honesty than do something that's not going to benefit your patient or you in any way. So go ahead and give us a call and we'll be happy to help. See you guys next time.